Okay, thank you very much for being with us today. I'm very happy just to have this sharing experience about the COVID-19, which was affecting, is still affecting so much of our lives, both as doctors, but also as simply citizens and so on. So I think that it's, first of all, let me say that I'm extremely happy to see many of you today. And I hope really to have the possibility in the near future to have the possibility to meet you in person, because of course this telematic or web meetings are very nice, but it's not the same thing that we are used to do when we are meeting together. We can discuss in a very informal way in person. So I think that having said so, I think that we can start. I will leave the B-roll just to present the situation in Turkey. I think that he will present some slides concerning the situation in Turkey about the COVID. And then we will move to one of the most affected countries for the moment, which is Brazil, with Carmelo de Souza. So welcome to everybody.
Thank you. Dear colleagues, and EHOK friends, as you know, my name is Birol Güvenç from the Çukurova University, Adana. I am also president of the Hematology Specialist Association. I would like to welcome you all to Eurasian Hematology-Oncology Group Ambassadors special webinar event called COVID-19 Experiences and Different Approach Around the World. Thank you for joining us today on this beautiful Sunday. We have a format non-profit scientific platform called the Turkish Hematology Networking Group in order to share the most updated data and the treatment options related to COVID-19. It later on became the platform where the hematologists started to support each other and keeping each other in the good mood throughout these difficult days the whole world is facing. The webinar project also came out as an idea from the interaction of this platform, and we have proposed it to our international family, whom we call EHOK friends. It is always accepted by the majority of them with a big pleasure. So today we present you to this event, which I believe will be a milestone for our big family. I would like to take this opportunity to thank each and every EHOK friends who accepted talk and share in such short notice in webinar starting with our beloved EHOK President Giuseppe Salio, Professor. Last but not least, I would like to thank you all the attendees who spared this Sunday to follow this meeting. I do hope the scientists will find the most effective treatment to overcome the virus as soon as possible. We send our prayers to all families who suffered from the pandemic and wish fast recovery for the ones who are still fighting the disease. Enjoy the webinar, and hopefully we will be able to meet each other in person at the 11th EHOK Congress, which take place on the October in Istanbul. The first, I would like to invite Dr. Carmina Antonio de Souza from Brazil. Dr. Carmina Antonio de Souza will brief about recent data about COVID-19 evolution in Brazil and São Paulo state.
And good morning, everyone. I would like to thank friends who invited me to talk about a very dramatic situation in this moment in Brazil. Excuse me. As you know, the coronavirus or COVID-19 is a pandemic situation, and all of you and I experimented the evolution of this problem. This is the situation 5 days before, when you can see Americas now is the more affected continent, with more than 2.5 million cases, followed by Europe and then other continents. In this week, the WHO say South America is a new epicenter of disease in this moment. And you can see here, US in the first place with almost 2 million cases. And in Brazil, in this moment, we have almost 500,000 people affected, and almost 30,000 deaths. Excuse me, next one. Brazil is a biggest country in South America. In terms of geographic area, is very similar to US, and we have about 230 million people. Brazil has 27 states, and you can see here the situation in green. You can see the states with more than 10,000 cases. And the problem in Brazil in this moment, the more dramatic problem in Brazil is in Amazon and Northeast, and of course, São Paulo and Rio. But in Amazon, the situation is too bad. On the right, you can see the cities, and you can see the disease spread in the all country. This is the curve of evolution of cases. And you can see now, as I told before, we now is very near to 500,000 people affected by disease. This is the curve day by day, when you can see a very dramatic evolution. In Brazil now is like the one World Trade Center each 2 days, or 3 Boeing 767 each day crash. And so is a very difficult situation. Here you can see the number of deaths by state. São Paulo is the state with more. São Paulo has 46 million people, followed by Rio in absolute number. But in terms of the relative numbers, the bad situation is in the Amazon. Here you can see day by day until the last week. We are now in the 22 epidemiologic week, and so this number is partial. Today finished the 22 weeks, and you can see the growth of number of cases day by day after March. This is the cumulative deaths. We have a curve ascendant until now is ascendant in terms of day by day and the epidemiologic week. As I told before, we are in this week 22, and so the last data is not final, because you have to include here the number of the last days. This is the cumulative deaths in selected countries on 20th day after the first death until the 88th day. You can see here the evolution of US in red, followed by Brazil is in green, and other countries like France, Italy, and Russia. This is the fatality or lethality rate in Brazil. Brazil is exactly in the now exactly in the median of the world, and you can see 6.6% of lethality rate compared to the world. Excuse me, this slide is in Portuguese, but here you have United Kingdom, Italy, Switzerland, Spain, world, Brazil, US, Iran, China, Japan, Germany, Korea, South Korea, Australia, and Russia. This is the mortality rate in Brazil and other countries. The worst situation was in Belgium with 764 per million people, and now we have about 86, but it's growing. This data is the May 19. It's very common and comorbidity. The most common in Brazil is cardiomyopathy, 41. No comorbidities, 36, diabetes. And one thing very interesting is the obesity, particularly in the young people that die in Brazil. Oh, excuse me. In the left side in red is women, and the right side men. And so in Brazil, we have the number more women than women. This is the states of Brazil. In green is the Amazon, is the north of our country. And the biggest state is Amazon. Amazon is like half Europe. And then Pará is big as well. And in blue is Northeast, and red is our region, the Southeast. In pink is in the Midwest and in South. Which is the situation? States with the highest number of cases, the São Paulo ranks first. We have now about 100,000 confirmed cases, and now numbers of today, it's 7,500 deaths in São Paulo state, followed by Rio, almost 50,000 cases, and data for today is 5,300 cases in Rio. After Ceará is in Northeast, followed by Amazon. And here is comprised the cases, and more than 50,000 cases in Amazon, almost 100,000 cases in Northeast, and in our region, Southeast is about 110 cases, and in South, until now, there are a few number of cases, but it's increasing because the winter is arriving in Brazil, and this is the zone cold in Brazil. The preventive measures done in Brazil. Everything starts in middle of March, and the first action was done in Santa Catarina, declare the state of emergency. One day after Rio, one day after Rio Grande do Sul in the south, and one day after the Rio Grande do Norte in Northeast, and São Paulo declare state of quarantine in March 24. This is the cumulative death by COVID-19 in Brazil states, and you can see São Paulo first, then Rio, followed by Pará, Maranhão, etc. In epidemiologic the week, you can see this plateau is not correct because we are finishing today the week 22. And so probably this curve will grow up. This is the confirmed case per million people. This is dramatic. You can see here the Amazon. Amazon is a big state, but few people living there, Indians living there, and you can see the number per million people. This Amazon, Amapá is in Amazon zone as well. Roraima is Amazon as well. Ceará in Northeast, Acre in Amazon as well. And you can see the states more affected by cases per million inhabitants are in North and Northeast. São Paulo is here. This is in green, is the median of Brazil, or the country. This is the confirmed cases. The incidence is very similar. This is the death per million. And I will read this. As you can see, the death in Amazon is 3 times of São Paulo or the median of Brazil. Amazon is very critical, the situation. In Amazon, only Manaus, the capital, has intensive care units, for example. Is a state like a continent, but with structures only in the capital. And this is Amazon, Ceará, Pernambuco, and the deaths per million in Brazil. As I told before, this number increased in these last days, and the numbers are much higher than this are showing. I will talk something about the cities in São Paulo. São Paulo is the richest state in Brazil. In São Paulo, we have 46 million people living, and half of these people living here in metropolitan area of São Paulo. We are here. I'm here. Campinas is here, near to São Paulo, less than 100 kilometers. And in São Paulo, this zone is where we have the epicenter in Brazil now. São Paulo, the city of São Paulo and metropolitan area of São Paulo. São Paulo has 12 million people of inhabitants. The metropolitan area of São Paulo about 22, 23. And in the beaches, we have 1,000 of beaches, 1,000 kilometers of beaches, but only 2 million people living here. And in inland, we have about 22 million people. And the disease, this is the region with the high quantity of cases, in yellow less cases, in white some cities without cases in São Paulo. We have a few number of cities in São Paulo, 45 cities, more than 500 we have cases of COVID-19. This is the curve in São Paulo by epidemiological week, when we can see the growth of number of cases week by week, and the new death week by week. Growing until now is growing. We do not reach the peak of the disease in Brazil, neither in Brazil or in São Paulo state. We are growing in the cases. This is a new cases in São Paulo. You can see the total of cases and new cases a day, and day by day, the new cases of São Paulo. The Brazilian context is dramatic because we are a federative republic, but you can imagine with this pandemic situation, now we don't have a minister of health. And our president is completely out of the fight against COVID-19. This was the editorial of Lancet where they talk about the pandemic situation in America and in Brazil. And in Brazil has the most cases and deaths in Latin America. And large cities like São Paulo and Rio are the main hotspots now, but there are concerns in early signs of that infection can moving inland. This is a movement now, the disease moving inland into smaller cities, not only in the big cities. Even without a vacuum of political action at federal level, Brazil have difficulty to combat COVID-19. About 13 million people live in favelas, or often with more than 3 people per room, and the social distance or isolation is almost impossible in this condition of life. Physical distancing and hygiene recommendations are near impossible for these environments. Brazil has a large informal employment sector. It's the worst in the last with the pandemic. The indigenous population has been under severe risk now. In these populations, are a high number of cases in this moment, and the disease is spread in the forests. Brazil is experimenting simultaneous crisis of health with the pandemic situation, the economy, but the economy, I mean, is not so important. We can overcome, in my opinion, but the political crisis is really very difficult in this moment. This has a direct impact, of course, in the combat of COVID-19. There seems to be, in part of federal executive, a false dualism between health issues and economy, inducing the people to choose between them and ignore scientific knowledge in favor of common sense. Despite of the global impact of virus, our president tell the risk posed by coronavirus has been exaggerated, refer the pandemic as a fantasy, and he discouraged these sensible measures of physical. And in 1 month, our president fired the Minister of Health over this agreement about the social distancing guideline, and nominate another Minister of Health, but this new Minister of Health stay less than 1 month and resign because the problem with chloroquine, the hydroxychloroquine. The president wants to include chloroquine forever for all patients early. Now we have an Army General assumed the role of interim Minister of Health. We don't have a Minister of Health at this moment. And with the General, Brazil published a recommendation for a public health system prescribed chloroquine. Attention, in this meantime, the major states' governors imposed measures to distancing and lockdown in several cities. World Health Organization suspends chloroquine recently because the side effects. And Brazil confirmed more than 100,000 cases, and the cases double in the last 10 days. Brazil confirmed more than 10,000 deaths. The number of deaths doubled in less than 2 weeks. And several cities in north states of Amazon and Pará began assuming lockdown measures in order to curb the spread of the virus. Other cities in other states consider doing the same. Brazil becomes the country with the most Brazil with the most new deaths in the world now, overcome US and overcome all countries in Europe. I mean, this is the last slides, and would like to thank you for attention. Thank you very much.
Thank you very much. Thank you very much, Carmino, for describing us this dramatic situation of Brazil. I think that indeed this is an example of what politics can influence indeed wrong decisions about how to run a pandemic like this one. Of course, it's not totally, I would say, not everything can be ascribed to them, but of course the behavior is extremely important. Other questions for Carmino? I think that one question from me is: a big problem is that we have seen there is a great difference in the rate of mortality among different countries. I would say certainly not always the number of the infections of the infected people detected are correlated with the rate of the deaths observed. I think that the only way in which we could probably, at the end of the day, establish exactly which was the mortality the death rate would be just to compare the mortality during the first 6 months, we can say, of this year with respect to what we had in the previous 6 months of 2019. What do you believe about this? We are surprised that indeed in Italy we have so many deaths, whereas, for example, in Germany, which approximately have the same number of infections, they have a much lower deaths ratio. And we are also surprised to see that it's not only a question of latitude, because we can see that as well in Belgium as well as in Netherlands, we have a very high rate of mortality due to COVID-19. Which is your possible explanation?
Beppe, and in my opinion, we have two main causes for that. First, how is the people? Of course, in my experience, most of cases are young people, but who died are the old people. The mortality over 60 is increasing. In our experience, 40% of people over 80 died in our experience. The second point is the structure. Of course, São Paulo state and my city and São Paulo city, we have many hospitals. We have a structure for intensive care. We have a structure in primary system, health system. We have beds for intermediate cases. And so the mortality is very low when you have a very good structure for diagnosis and treatment. It reduces very much. It does not succeed in Brazil, for example, in Amazon or in Northeast, where the health structure is too bad, is insufficient to support the number and the severity of cases. We have to diagnose this early. As earlier you diagnose the cases, the better evolution of the cases. It's very important, the saturation of oxygen. When the patients arrive in primary health system and present a low saturation of oxygen, you immediately should recover and treat the patients, and you reduce very much the mortality when you do it. The reduction of saturation of oxygen is before the respiratory symptom, and is a very sensitive factor. And so you have factors dependent of the patients, but you have, in my opinion, the most important is the structure to support the epidemic. When you have the beds, you have doctors and nurses and physiotherapists trained for face the problem better to reduce. Our mortality in Campinas is one third of São Paulo, for example. We reduce it very much with the good structure and early diagnosis. We test with RT-PCR all symptomatic cases, and now we are testing the population, because about only 1% of our population had contact with the virus. It's different of Amazon. We have areas in Amazon where 25% of patients or population tested positive. And so the contact of population of Amazon with virus is very, very high compared to south or southeast in Brazil. I don't know if it's clear.
No, it's clear. It's clear. Although I must say that in Italy, fortunately enough, we have been able to avoid the saturation of the ICU. And in spite of this, we had many more cases who died with respect to what happened in Germany. And so it's not only a number of what the swamps, which can indeed define for this, is just, and not even an early treatment, because the early treatment, we know that probably is not effective. But there is something that at the moment is very difficult to explain. Now, there is a question.
We don't know all factors involved in this. We don't know.
Yes, absolutely. It's very strange. So there is a question for you. Probably you can see it. Do you see it on the question and answer column, which is on your right? However, I will read it for you. What do you think about the effectiveness of chloroquine on COVID-19 therapy or prevention? Which is the Brazil, let's say, opinion, or which are the guidelines in Brazil? This is a question coming from Shimu Serpel.
In my opinion, we have no definitive evidence to use chloroquine. It's not opinion. We have two environments in chloroquine. One environment is scientific. The clinical studies should be finished and published. In this moment, we have 7,000 papers in the 4 months. It's unbelievable, the number of papers. And I'm not personally, I do not agree with the chloroquine in large amount of patients. The other environment is the ethic. If patients and doctors decide to use chloroquine is available in Brazil. We use it to treat malaria and use it to treat the autoimmune diseases, and so depends of. But I'm not for a public. Using a large amount of people, I'm not agree. I'm not agree because the side effects are not. The problem is side effects. We don't know if chloroquine runs or not, and the side effects is well known, particularly the cardiopathy, arrhythmias, and other kind of side effects.
Yes, I agree with you, even because if it has to be used, most patients, these are the patients, elderly patients, and therefore maybe they can have problem of toxicity more frequently than young patients. So I think that we have to move now. And Mustafa, are you online? I cannot see you. Mustafa, can you open?
Yes, I heard you, Saglio. I'm very happy to see you all very healthy and safe. And I hope that everyone is healthy and safe during these challenging pandemic days. The humanity is still fighting against COVID-19 pandemic, even though I would prefer to talk with all of you face to face, but still it's okay. It's nice to meet you online. My topic is about COVID-19 coagulopathies. I would like to focus on the pathogenesis, prevention, and the treatment. I think that my colleagues, Dr. Sevgi Kalayoğlu Beşışık, will talk about the situation in Turkey regarding COVID-19 pandemic. Just a second. Okay. As we all know that COVID-19 associated coagulopathy is a very challenging and very critical clinical situation and very close relationship between the mortality and the coagulopathy. And most common patterns, as we all know, that characterized by the increased fibrinogen and the dimer level. And these two parameters are also correlated with the CRP level of the patient. And we also observe minimal prolongation of APTT and PT level, and we observe mild thrombocytopenia, which is very important because it's totally different than classical DIC. Near 70% to 95% of severe COVID-19 patient has only mild thrombocytopenia. And because of these findings, we cannot classify this coagulopathy as DIC according to the ISTH criteria. And in the literature, we know that the thromboembolic complication is very frequent in hospitalized COVID-19 patients, ranging from 5 to 15%, and some cohorts also shows that the incidence of this pathological event is higher, maybe up to 45%. As you see here, the clinical course and the risk factors for mortality in adult patients is very important. This article published in China in the early days of the pandemic, they were documented that the increased D-dimer level, serum ferritin level, and also the prothrombin time is really associated with increased the mortality of the patients, especially if the D-dimer level is higher than 1 milligram per liter. As you see that the risk is increased abnormal, as you see, it reached to 18 times. And the other important point is you see here abnormal coagulation parameters are associated with poor prognosis. In this article, you see near 72% of all non-survivors met the criteria of the DIC when compared with 0.6% of survivors met the DIC criteria, indicating the role of the coagulopathy and the on increased mortality rate. This is very critical. These parameters, these two parameters, is really related with the high clinical mortality. And another studies also shows us that, coming from France, including 150 patients, COVID patients with ARDS, coming from 4 different ICU units in France, including 150 patients, and near half of these patients has thrombotic complications. And near all of them has elevated D-dimer and fibrinogen levels, despite the normal platelet levels, despite the mild prolongation of PTA, PTT, and antithrombin 3 levels, which is not a critical, which is not a classical DIC. As you see in the slide, that the ISTH score is less than 5 in all patients, in all 150 patients. And also they demonstrated that von Willebrand factor level and also von Willebrand factor antigen and factor 8 is also increased. And interestingly, we really do not know the exact role of lupus anticoagulants and lupus antiphospholipid antibodies in the pathogenesis of COVID-19 coagulopathy, but near 90% of all patients in the series documented that the LAA antibody is positive. Excuse me. And as you see here, unfortunately, anticoagulation cannot prevent the thrombotic complications. Excuse me? Okay. Near 17% of patients in the series has pulmonary emboli despite the coagulation, which is very important. And near 42% of all patients developed life-threatening thrombotic complications. And furthermore, COVID-19 leads not only microthrombus in venous system, but also large vessel. It involves large vessel arteries and created thrombus. It is very, very interesting findings. This article was published in New England Journal of Medicine, an anecdotal case. I mean, only including 5 young patients which that they presented with acute ischemic large vessel stroke. And we really need to know the association between large vessel stroke and COVID-19 patients, especially in young patients. We really require further investigation to understand the pathology of this phenomenon. This is a slide shows us the pathogenesis of coagulopathy in COVID-19 patients. As you see that the trigger point, the trigger factors, including excessive immune response and cytokine storms, increase the level of the cytokines, and local and systemic inflammatory response. And these changes in COVID-19 patients can cause a kind of hypercoagulability and a kind of endothelitis, means it's a kind of endothelial injury. And this COVID-19 induced hypoxemia leads the vasoconstriction and also the endothelial dysfunction, and also increase the expression of some prothrombotic genes and PAI1 level. On the other hand, also COVID-19 during the COVID-19 in COVID-19 patients, increased pro-inflammatory cytokines also lead the endothelial injury, which is really critical for the patients and can cause the release of ultra-large von Willebrand factor multimers. And we really need to know the understanding of the role of ADAMTC13 in this pathology, because we really do not know the exact role of this ADAMTC13 level, and we really do not know the relationship between ADAMTC13 and endothelial injury. But we know that because of the endothelial injury, release of the ultra-large von Willebrand factor multimers can detected in COVID-19 positive patients. And also they express, overexpress the tissue factors, And we also observed an imbalance between increasing the procoagulant factors and also decreasing the normal natural coagulation inhibitors such as antithrombin, protein C and S. And as I said before, that the endothelial injury in this group of patients is also very critical. And we know that SARS-CoV-2 virus can invade the endothelium and can cause an endothelial injury, a kind of infection called as endothelitis, and it is provoked the generation of the thrombus in this group of patients. Another phenomenon which is which is defined by Gonagal and published in Lancet Oncology, in Lancet Rheumatology, called as pulmonary intravascular coagulation. And this pulmonary intravascular coagulation looks like mass-like syndrome. I mean, macrophage activating syndrome, characterized by the microthrombus and also intrapulmonary hemorrhagia. And as I said before, that we really do not know the role of the antiphospholipid antibodies. As you remember that we, in French group studies, they documented near 90% of all patients has LA positivity. And in this article also, which is published in New England Journal of Medicine, it's also an anecdotal case, including only 3 older men who had comorbidities such as hypertension, diabetes, and stroke. And these 3 old men has also antiphospholipid antibodies, and we really need to define the exact role of these antibodies in the pathogenesis of COVID-19 coagulopathies. And we all know that anticoagulant treatment is really associated with the decreased mortality, especially in severe coronavirus disease. Like if the D-dimer is higher than 3.0 microgram per milliliter, we really helpful to use anticoagulant treatment. And if the patient's SIC score is higher or equal to 4, then we really need to use anticoagulant therapy. I would like to also talk about some guidelines regarding the management of COVID-19 coagulopathies. The first one is ISTH guidelines. They are very clear that in all hospitalized patients, we really need to start prophylactic dose of low molecular heparin unless the risk groups such as bleeding patients and low thrombocyte and the patients with low thrombocyte count such as 25,000, less than 25,000. This is very clear. In all hospitalized patients, we really need to start anticoagulation if we have no contraindication. NIH and ASH guidelines is very similar to ISTH, and they also recommend to use low molecular weight heparin in hospitalized patients unless they are contraindicated. And they also should not be, they also recommend that we should not start anticoagulation, VT prophylaxis, or at therapeutic dose, doesn't matter, for non-hospitalized patients. They don't need to use that kind of therapies. And this is also very important, and we really agree to use a little bit high dose of low molecular heparin in especially COVID-19 critically ill patient. This article published in Lancet recommends us that if the patient with severe COVID-19, we really might need to use high dose of thrombophylaxis. I took this algorithm from the Imperial College. It's their recommendation. As you see on the right side of the table, you see the dose of the low molecular weight heparin, and on the right side, the level of the dimer and weight. It is very practical for clinical use, as you see here. We really need to start low molecular heparin in hospitalized patients if they have no contraindication, according to the level of the dimer and according to the weight of your patients. And as I said before at the beginning of my talk, that my colleagues will tell the situation in Turkey, I just would like to say a few words about Turkey. Turkey took control of COVID-19 responded fairly and very quickly, and testing, quarantine, isolation, contact tracing are being conducted. We have some movement restriction. The over 65s and under 20s were locked down. Weekend curfews were imposed during the pandemic, and big cities such as Ankara, Istanbul, Izmir, and some others were sealed off, and we really did not compensate during the pandemic. We have a higher number of ICU capacity, really, luckily, and we start early treatment, especially if we start low molecular weight heparin very early. And the Turkish Ministry of Health guidelines also recommends the early thrombophylaxis for all hospitalized patients. And thankfully, we reach out of the peak point of the curve and contain the virus right now. And we are now on the right side of the curve, and everything will be better, I hope. And everything will be better not only for Turkey, but also in all over the world, all countries and humanities. I hope that we will see all of you face to face near future. Thank you very much for your attention.
Thank you very much, Mustafa, for this very nice presentation. I think that this is one, from the pathological point of view, one of the most important aspects that we have to consider in treating, I would say, although many of us are not directly involved in the treatment, but as a hematologist, my department, for example, has been requested, and we have done a real sort of guidelines for the treatment for all our hospital. And one of my collaborators has been also requested to write something, some recommendation together with the American Society of Hematology. So I think that this is a very important, I would say, talk for us. Other questions? I don't see questions at the moment. Other question? You can speak directly if you don't want to write the question.
I just would like to add a few points, if you allow me. You know that luckily in Turkey, the scientific committee included the hematologist and pulmonologist, internalist, infectious disease expert, public health expert, and they always published updated guidelines for all Turkey, and all of the physicians in Turkey do the same during the pandemic. And everybody knows what should they do for the patients. This is very critical and play a critical role to manage the patients, I think.
Okay, absolutely, I agree.
Can I ask a question?
Now we have. Yes, Thomas, do you want to ask?
Yes, because
Please.
I'm not able to send it via chat. I have a question. Are there any data that we are dealing with the genetically different strains of coronavirus in the different parts of the world? Maybe this could explain the differences in the mortality rates among different countries, Italy, Brazil, Belgium,
Yes, I
Germany.
think that there is the Cambridge University published an article about the type of the coronavirus. They defined three different type of coronavirus, which is called A, B, and C, and their virulence may be a little bit different, but I think that the most important point is how to handle the pandemic, and the second one is the characteristics of the patients. I think that, for example, in US, because of the high rate of obesity, high rate of hypertension, high rate of diabetes, which is very critical, more than 80% of all patients has at least one comorbidities. I think that it plays a critical role also. In Turkey, I really do not know the Turkey generally, but in our hospital, I know that the average age of the patient is about 40 to 50, not more. So the age of the patient also is very critical to manage the patients, I think.
Sergio, I have also a question.
Yes.
Please.
I want just to comment, Professor Salio, if you don't mind. Salam al-Kindi.
No, please.
Beppe, can you hear me?
Yeah, so
Yes.
Maybe we can answer the question after the session. After the panel,
Yes.
there will be a question, because this way we are.
Otherwise, we are running too late. We're already 10 minutes late.
Please,
So we will have a discussion at the very end of the session. We will have a general discussion touching all these points. Now we can please mark them or send them a question.
Thank you.
So now, if we can go now to Oman. Salam, are you online?
I am, yes.
Yes, please. You have to talk about the. Please, Salam, go. We cannot see you.
Yes, I am here.
Yes. No, we can hear you, but I cannot see you at the moment. Okay, please proceed. It would be nice to see you.
They are not allowing me.
No. You have to mark on the mark of the camera, which is on the left low part of your screen.
Yes, I did, but the system is not allowing me. So I don't know whether that is because of the organizers there, the IT people.
No, I think that is due to something which your security process in your institution probably. No. Are you speaking from home or?
No, I'm in the office.
Yes. So I think that this is something which is not allowed by your university. Please proceed, however. We can hear you very well.
Thank you. Okay, my talk is going to be about hemoglobinopathies, and I reflect also on the COVID situation in Oman. And luckily, my talks have been made easy by the previous two speakers, Dr. Carmino and Dr. Mustafa, because I will be touching on some of what they said, and also compare Oman with Brazil, where it is appropriate. So Oman has a very high prevalence of hemoglobin disorders, and this is probably applicable to many countries in the region. We have about 10% of the population carry a gene for beta gene abnormality. The most common, of course, is sickle cell gene, about 6%, and then beta thalassemia, 2.2%, and then there are other rare hemoglobin disorders which account for the rest of the 10%. We did a lot of studies, and they are consistent with the same level that I just mentioned. So this is the situation of hemoglobinopathy in Oman. Just to give a little bit of explanation, the coastal area of Oman has more of beta thalassemia, and the inland has more of sickle cell gene. And there are some special mutations like an S Oman and hemoglobin dhafar, which are exclusive genetic disorders that are only seen in Oman. One is for sickle cell and one for thalassemia. So there is a fair play in this situation. We expect to have about 8,000 sickle cell patients in Oman and about 2,000 thalassemia, and these are numbers similar to Bahrain. There's about 70,000 in Saudi Arabia, and these are the numbers in the US and Brazil. What I hear and what's been published. Oman has a more of African haplotype, so 75% of the sickle have an African haplotype, Benin and Bantu, and 26% of Arab Indian, which is a milder sickle, which is different from Kuwait, where Kuwait has a more of the 80% Asian, what we call Asian haplotype or Arab Indian. So Oman, Kuwait, and the eastern province of Saudi Arabia have similar haplotypes of the Asian haplotypes, whereas we predominantly see African haplotypes, which means that our patients are more complicated. If we go to the COVID-19, up to today, we have about 11,000 confirmed cases in Oman. If you allow, we have about 4.6 million in Oman, and so if you do a calculation, we are almost similar to the incidence of Brazil. If you take about over 200 million people, but we expect with that incidence about 600 deaths. But in fact, we have only 42 deaths among this 11,000. One of the reasons that I wanted to comment earlier, some people have suggested that our population take up more vaccination, childhood vaccination, which might be contributing to the low prevalence and lower deaths rate among. So there is a little bit maybe mounted immunity to some of these viruses and others. So this is one possibility. And our population is also a younger population than that of Europe or the US. These are the daily cases this today actually we are continuing to rise still, unfortunately. Today we have about 1,000 cases, new cases recorded in Oman, and then daily, these are the outline of the daily cases that are happening. Mostly they are in Muscat, and Muscat was the capital of Oman was on a lockdown until 2 days back when it was open. So people from the regions were not able to enter Muscat or exit to outside Muscat unless they have a permission to do so. These are the deaths. As I mentioned, there are about 42 deaths recorded due to COVID-19. Most of the highest number we had is about 3 deaths per day, which is, of course, to the population, it's a reasonably low numbers. If we go a little bit, I actually don't want to spend time on this COVID. I'm sure there will be other people, but people think that it has been transmitted as a zoonotic, that's been transmitted through animal transmission from bats to ganglion, or that is what's being thought. And we await further studies on this area. The complications of the disease are important because for hemoglobin disorders, because many of these patients present with with respiratory symptoms, and also, as mentioned earlier, they also present with thromboembolic complications. And so these are the vast majority of symptoms, including headache, including cough, dry cough in a majority of patients, and also other upper respiratory tract symptomatology. This is a study, a retrospective systematic analysis of about 5 studies in which 1,500 patients were included, and mortality of about 2.4, and ICU admission of 7%. And many of these patients had respiratory symptoms. The only question that none of these patients had what talked about olfactory disorders and so on, as in anosmia was seen to be one of the features that are seen. So maybe some of these patients which are not admitted may not be picked through these studies. We know that the COVID attached itself through the ACE receptor by using the TMBRAS activation, and probably this is an important step in the pathogenesis of COVID. The role of ACE inhibitors is not established. Now, I want to mention, just before I go to the hemoglobinopathy, coagulopathy. I think my previous speaker has mentioned all of these, but there is that inflammatory component that triggers coagulopathy, and leading to the various thrombosis, and also including arterial thrombosis. And this is very important for hemoglobinopathy because these patients are actually at increased risk of getting thromboembolic complication. And this is actually a reasonably good symbol diagram established by the STH for the COVID-associated hemostatic abnormality. So if the patient has a high D-dimers of less than 2 to 3 folds with normal platelets, these patients will require a fixed dose of low molecular weight prophylaxis. But if they had a much higher D-dimers, 3 to 6 folds with lowish platelets and a prolonged ABTT, then these patients require maybe double dose of low molecular weight heparin. And if they are in ICU with low platelets and a prolonged ABTT with greater than 6 times the D-dimers, then these patients may require double dose or even further thrombolysis, or maybe even experimental drugs. And this has been talked about, thromboembolic complication of COVID. So sickle cell patients are particularly prone to infectious diseases and acute chest syndrome. And acute chest syndrome in adult patients has been already associated with high risk of thrombosis in the pulmonary arteries, but pulmonary thrombosis is also a major concern in COVID-19. So both conditions combined may generate an even higher risk of thrombosis in patients with sickle cell disease. And so it requires more aggressive treatment in these particular patients. And we know that one of the second commonest cause of admission and the first cause of death in sickle cell disease is due to acute chest syndrome. And so this is very important complication that we need to take care of. The only and also severe illness is thought to occur predominantly in adults with advanced age and underlying comorbidities. And so these sickle cell patients are at higher risk for respiratory infection and subsequent pulmonary complication, as I mentioned. Now, the only other issue is also sickle cell disease is an African, a predominantly African disease, and reports from the United States in particular that COVID actually affect disproportionately more African Americans than other ancestries. And I will come back to that. I will come back to that point later when we talk about some of the registries that we have for sickle cell COVID cases. Now, maybe you could argue that these patients have different access in terms of insurance and so on. And so this is maybe also contributing to the disproportionate effect of COVID-19. The symptoms and manifestations so far in sickle cell has remained mild to moderate, looking at our local and also looking at the international data that we have on sickle cell disease. If we look at our data, we have had 3 sickle cell patients confirmed to have COVID. One patient, patient number 3 actually is a 43 years old, and she came in with cough and chest pain and anosmia, loss of smell. And she had a baseline hemoglobin around the same level. She did not need to be admitted, and she was treated with pain medication. The second patient is a male, 26 years, and he had complained with chest pain, cough, and fever, and he actually dropped his hemoglobin and dropped his platelets also to about 25,000, and with a high D-dimers. And the patient needed blood transfusion, but he also has an enlarged spleen because of sequestration, and he was given antibiotics and transfusion and stayed 3 days in the hospital, and he was discharged. The last patient was 13 adolescents, and she also needed to be admitted, but also stayed only 3 days. Her hemoglobin was around 7, and she received a blood exchange and did well on blood exchange and antibiotics. D-dimers were slightly high, but she was not given any prophylaxis heparin. Similar data coming from the UK, where they published in the British Journal of Hematology 4 cases of COVID confirmed children and adolescents, and you could see that many of these patients actually required exchange, or all these patients required exchange transfusion. But it's interesting also that when you look at their D-dimers and also their factor 5, it was actually elevated in the cases where it was done, and suggestive that this coagulopathy situation is also very much heightened in patients with sickle cell disease, as in the general population. And I expect that the thromboembolic complications will probably even more important. So far, COVID in sickles, we have remained limited. Patients tended to do self-isolate. I actually talked to my colleagues, and we had a webinar with TIF. The thalassemia patients also do similar situation. In Italy, I think they had about 11 patients with COVID in thalassemia with Professor Capellini among about 5,000 patients with thalassemia. And so it tended to be low, probably because the patients tend to isolate themselves at home and do not mix. And the thalassemic in particular are at disadvantage because the access to blood in these circumstances has been a little bit difficult, and access also to transfusion centers has been also difficult. And so patients may end up going to lower hemoglobin than the usual before they receive their blood transfusion. Just to mention that among a registry by the Wisconsin University of 190 cases from the US, the rest of the world, Brazil, Oman, and so on, patients stayed about, on average, about 7 days in the hospital, and mortality of about 7%. This data is not published yet, but it is actually accessible on the website, and so people can have a look at it. And many of these patients treated with blood transfusion, exchange transfusion, and also thromboembolic prophylaxis, as with the other patients. I think this is my last slide. Thank you very much.
Thank you very much, Salam, for this nice presentation. I think that we have to run a little bit, so we will discuss all together at the end of the meeting. So the next speaker, can you show me the program? I do not remember. It seems I remember well. Can you show me the program? Yes, thank you. So it's Evangelos. Evangelos will talk us about the myeloma management during the COVID pandemic. Please, Evangelos.
Hello, thank you for the kind invitation to talk about a paper that has just been appeared this week on Monday in Leukemia about the European Myeloma Network approach for the management of patients with multiple myeloma. I think that this is very important because the myeloma community wait for such guidelines as we have patients, these are my disclosure, we have patients who receive novel drugs, and also you are the first of it that see, as we have not made the final draft, but this is the ESMO guidelines in preparation, just to mention that the management of myeloma becomes extremely difficult as daratumumab goes up front, and I believe that it is very important to know that both Dara-VMP and Dara-RD has been licensed for patients who are not eligible for transplant, while the combination of daratumumab with VDD has been licensed for the use of newly diagnosed patients who are eligible for transplantation. So I believe that it is important to know what would be the next steps for patients who relapse on myeloma. And as Dara goes up front, you understand that this becomes extremely difficult because you can see here, for example, that someone who has received Dara VMP or Dara VDD and goes to second line, then we have no data for patients who receive daratumumab. But even for those patients who receive VRD up front and they are refractory to lenalidomide, then you can see that only in the second line, only POMVD and DARA-KD can be given to these patients. And although POMVD has been licensed in Europe or DARA-KD in the United States, I don't know if these are broadly used in other areas in our planet. So I believe that the myeloma treatment is becoming extremely challenging, and due to that, the COVID situation also makes the whole spectrum very, very difficult. I'm not going to talk about the COVID infection because this has been analyzed by other speakers, but we all know that one of the major issues is the infection of the respiratory tract, mainly the lower respiratory tract with pneumonia, but also we have seen a lot of patients with so different clinical picture within the same family. So we had a family, for example, 2 days before that the father had pneumonia and need to be hospitalized. The mother had a flu-like symptoms, and the two children have for 2 months loss of smell and taste, and with no other symptom at all. And all of them are PCR positive. So you see that there are so many different pictures of the disease. It's a disease that also has a lot of hematological findings, and we had a review paper in almost 1 month and 1.5 months before in American Journal of Hematology, where we have put all together all the hematological complications of COVID that were reported till that day. And of course, lymphopenia is one of the most important and cardinal laboratory findings. But also this lymphopenia, as well as the neutrophil lymphocyte ratio, may also have prognostic value. More importantly, we do know that we have increased inflammatory indices like the increased LDH, CRP, and IL-6 that help to identify cases with dismal prognosis. while biomarkers like high serum procalcitonin and ferritin and blood hypercoagulability is common among the hospitalized COVID-19 patients. And also, as you know, the D-dimers, for example, is a marker of very poor prognosis for these patients. If we go to the coagulation picture, we've seen that many times we may see disseminated intravascular coagulation, which necessitates continuous vigilance and prompt intervention, and the pharmacological thromboprophylaxis because of the hypercoagulability of the virus. With low molecular weight heparin is not only highly recommended, at that time it was highly recommended, now it is definitely recommended by all the important societies of thrombosis and hemostasis. Regarding multiple myeloma, we have neutropenia. So do we have any data that from the Italy and China that had the first patients about the risk of COVID-19 in patients who had temporarily neutropenia? There is only one paper in that, and the patient who participated in this paper suggested that if they had a history of cancer, then they had a higher incidence of severe adverse events, defined as the percentage of patients admitted to an intensive care unit requiring invasive ventilation or death. We don't have data on temporary neutropenia because of chemotherapy and the risk of COVID. Another issue is how can we change the therapeutic modalities in order to minimize the visits? And the American Society of Hematology in the website of us suggests that whenever possible, it is recommended to use weekly and oral regimen. So having all this in mind, we produced the European Myeloma Network recommendations for patients with plasma cell neoplasms, including MGUS or asymptomatic multiple myeloma. But for these specific patients, we don't have changed a lot the guidelines. The only change is that lenalidomide is used in several countries like Spain for the high-risk smoldering. So possibly this can be taken into consideration, but we have not officially recommended that. We wait for the ESMO guidelines to check if lenalidomide is going to be recommended with high level of evidence for the asymptomatic myeloma treatment. But for the other myeloma patients, the symptomatic patients, then we suggest that in countries or local communities where the COVID-19 is widely spread, the myeloma patients should have a PCR test of nasopharyngeal swabs for the coronavirus before any hospital admission, starting a new treatment line, cell apheresis or autologous transplantation in order to avoid the world spread and infections. The question is, what is going to happen if someone is found to be positive PCR but with no symptoms for the COVID-19 infection? So for these patients, we recommend them 14-day quarantine. What is going to happen if during these 14 days the patient develops symptom? Do we have any drug that we can give? Though this is according to the local guidelines. But on the other hand, if someone has a positive PCR test with symptoms, then we have also to delay treatment. But what's going to happen if the treatment is totally necessary for the patient because of an aggressive myeloma? So the treatment should not be delayed for the newly diagnosed patients with active disease, mainly if the patients have, even with COVID-19, if the patients have acute renal impairment or very high risk features like high LDH. Induction treatment can be administered for an extended period for up to 6 to 8 cycles. The combination of bortezomib with lenalidomide or thalidomide and dexamethasone VRD or VTD, as well as the combination with daratumumab, is the preferred induction therapy. We have to postpone mobilization, stem cell harvest, conditioning, and autologous transplant, mainly in patients with standard risk disease. But for those patients who have high risk disease, should the stem cell harvest without transplantation should be considered for those who receive daratumumab and or lenalidomide. But for those with high risk disease, as I previously mentioned, then the patients have to go to autologous transplant after 6 to 8 induction cycles if they don't have a COVID-19 positive PCR test. In case of close contact with a person diagnosed with COVID-19, the stem cell harvest and any transplant procedure should not be performed within at least 14 and preferably 21 days from the last contact. Patients who are in the maintenance phase of their treatment should continue with their oral therapy and reduce visits to the clinic, whereas subcutaneous bortezomib administration might be omitted or delayed depending on the achieved depth of response and the risk of relapse. Regarding the non-eligible for transplant patients, so their treatment should be based on all oral regimen if possible, like lenalidomide and dexamethasone, especially for the unfit patients, where the addition of bortezomib or daratumumab can be considered if the patient has high-risk disease or for those without sufficient response to lenalidomide and dexamethasone. But for those who are fit or they are intermediate fit patients, then the RD can be considered only as a bridge for 2 to 3 cycles in case of COVID-19 pandemic at a peak in the hospital. Otherwise, the approved VRT or daratumumab-based therapies should be considered. We recommend the reduction of dexamethasone to 20 milligrams weekly, whereas de-escalation or even interruption should be considered for responding patients, especially after the completion of 9 cycles of treatment. For the relapsed refractory myeloma, it is also that before every line of treatment, a PCR test has to be done. We have to prefer orally administered agent if appropriate, of course, again, balancing efficacy and safety. And for those regimens that are used twice weekly, like bortezomib and mainly carfilzomib-based treatment, then we suggest once weekly instead of twice weekly, and monthly daratumumab infusions. You all know that the patients who receive oral treatment can be in the clinic monthly, like with IRT, while if we use carfilzomib, for example, they have to have 6 visits per month. And that's why I suggest that IRD is a good regimen. This is a recent publication from our group suggesting that what you expect from the phase 3 study, the tourmaline, is what you expect in the real world data. These are the 2 curves of the real world, which is the blue curve, and the tourmaline, which is the red one. We had exactly in this population, exactly the same follow-up period. So you can see that the median EFS that you expect is the same. On the other hand, if you use carfilzomib, you can go to the once weekly based on the arrow results, where you can see that if you use 70 milligrams once per week, this is even better than the twice weekly carfilzomib 27 milligrams per square meter. Of course, we don't know if it is better than the 50 2 milligrams per square meter, which is the approved dose for the twice per week. But just to let you know that if you compare VRD, KRD, and IRD, and this was a recent paper, you can see that for patients who receive IRD, for example, compared to KRD, who had better time to next treatment, mainly because the majority of these patients were frail. So you can see here the frailty score of the patient. So if the patient was fit, then carfilzomib did much better than VRD and IRD. If the patients were frail, carfilzomib did worse compared to VRD and IRD. So I think that it is logical when we have intermediate to frail patients to use IRD, which is an oral drug, and if we have fit patients with relapsed refractory KRD with K once weekly. And you can see here the different comparisons between IRD and VRD. Again, you can see here that IRD is better if you have a prior IMiD exposure. If you compare IRD and KRD, you can see that in the majority of the comparisons, KRD seems to be advantageous. One important issue is the thromboprophylaxis. So, you know, I previously mentioned that the coronavirus has thrombogenic potential, and the antithrombosis prophylaxis in myeloma patients should be administered according to the international guidelines. However, for countries with high incidence of COVID-19, the low molecular weight heparin may be considered over aspirin, as thromboprophylaxis in myeloma patients under lenalidomide and pomalidomide administration, irrespective of that thrombotic risk. And regarding the use of low molecular weight heparin in myeloma patients with asymptomatic COVID-19, because this is also an important issue, or with mild symptoms, not requiring hospitalization, even in the absence of minor administration, several ongoing trials will reveal the prophylactic value of low molecular weight heparin in this aid. We had a lot of discussion among the co-authors, who are the most important names in myeloma in Europe. There were a lot of physicians who were against that. There were a lot of physicians who were in favor of using low molecular weight heparin in all myeloma patients with asymptomatic COVID, even if they have not had IMID administration, but we made it as low recommended as possible. So in conclusion, for the myeloma patient under the COVID pandemic, we have to reduce the hospital visits in order to balance efficacy and safety. The PCR testing is obligatory for all newly diagnosed myeloma patients and those who start new line of treatment and before autologous transplant. We have to use more oral drugs if possible to postpone the transplant in standard risk patients, but not in the high risk. Maintenance with oral drugs can be continued. In case of COVID-19 infection, we have to follow the local guidelines, as there is no data regarding how we treat a COVID-19 infection in myeloma patients to date, as there is only one published case report to date. And with that, I would like to thank you for your attention, and I hope that this was fruitful for every one of the participants.
Thank you very much, Evangelos. Very clear presentation. Now I think that we will discuss it later. Now it's term of Ahmad, Lebanon. Ahmad, how are you?
Fine. How are you, everybody? So, 15 minutes
we'll
to talk about.
Okay. More difficult to use only oral drugs for acute leukemia, no? So we have to treat
some oral drugs, target therapy are here, not like multiple myeloma. I agree. I'm happy to be with you among you today. I hope in October we'll see the others. In Lebanon is a small country, 4 million inhabitants, but we have 2 million of refugees. So since 25 February, the government was tough in terms of controlling the spread of COVID-19. Since 25 February, we have registered 1,172 COVID SARS positive patients. 700 recovered. 83 are still in the hospital, with 6 in ICU. And we registered 26 deaths, only 26 deaths. It is not so, it has not been so devastating like in other countries. I agree with Salam Oman. We have the same profile of population. Maybe for that we have a lower number of COVID. The Lebanese Society of Hematology tried the last 2 months to establish a kind of proposal and guidelines in order to homogenize and harmonize the treatment in Lebanon. The majority of the big part of these guidelines is how to reduce transmission of SARS in leukemic patient and other hematological disease patients. My talk today will be on acute myelodysplastic leukemia and acute lymphoblastic leukemia. So what we are doing now is a kind of consensus, what we saw published by the international societies like ASH, EHA, EBMT, and so. And it was done according to the Lebanese condition, the availability of drugs, the population, the refugees, and how is spreading the virus in our region. We are doing testing for SARS-CoV-2, for AML, for all newly diagnosed patients at start of any cycle. if fever and or symptoms at any time, and for allo donor and the recipient for auto donor and for the patient, and at the collection of stem cell, the mobilization of stem cell. If there is a suspicion of any symptoms, we take into account the CT scan in order to do a good triage for the patient before the admission of the patient to the hematological unit. So we are doing, like Dr. Terpos said, like the ASH, the triage and the how to prevent the spread between the patient and the medical and paramedical personnel. We try to do cytogenetics and molecular biology for the majority of the patient. One, it is available and affordable because starting treatment, because it will help us, it helped us to choose some targeted therapy or to delay some treatment if it's not urgent, awaiting the appearance or the pandemic will be more or less devastating. And we are following also the MRD, because if we have an MRD negative, we can adjust and reduce the cycles of consolidation in leukemic patients to avoid the admissions and hematological and other complications due to the treatment. Concerning, I'll present 2 or 3 slides as a background to background and to explain why we choose some strategy. So fludarabine, we know that fludarabine, cytarabine, and GCSF with the Mylotarg induced a higher DFS and survival in patients with core binding factor acute myeloid leukemia. And we know that CPX-351 in secondary or MDS is a good drug for these patients, and easily feasible than 3.7 and less toxic for the majority of the patient. Particularly in elderly patients. So for eligible patient for chemo as induction therapy, the 3.7 regimen is still here. We are not using fludarabine as reported in by many societies, because this is a very important immunosuppressive drug. We are using CPX-351. It is not available for the majority of the patient, but it is, if it is available, we are using it as alternative to 3.7 and Mylotarg, not 2 doses, but 1 dose in the action therapy for translocation 821, inversion 16, and CBF. We are using this in association with chemotherapy, sure. Because of venetoclax and hypomethylating agent was reported in the literature as efficient for elderly patients with acute leukemia and MDS. So we are proposing for uneligible patient for chemotherapy, hypomethylating agent plus low dose RC, and particularly most frequently hypomethylating agent plus venetoclax. This is easy to be done, on outpatient basis, and the patient doesn't need to go to the hospital except for supportive care, but not frequently like 3.7 where we have to the patient in the hospital for 3-4 weeks. So we also we are using venetoclax more and more because, as we know, venetoclax is an interesting drug for patients with IDH1 or NPM1, and we know that this is a frequent. These are frequent abnormality mutations in AML, and you see on the slide and the previous one that HMA plus venetoclax is not bad in such a patient, in elderly patient particularly. And on this slide, you saw that this NPM1 patient, CR and the CR the CRA, good CRA level, like IDH1 and 2, particularly IDH1 patient. And this could be, this is a drug, what we are using for a patient with NPM1 and IDH, because we don't have systematically and frequently an IDH in Lebanon for our patient. Here you have the overall survival for NPM1, IDH1, IDH2, which is interesting in such patients. And we know that anti-FLT3 at first-line therapy, we have the RATIFY study here with midostaurin, gave overall survival significantly superior to chemotherapy alone, when midostaurin was associated to chemotherapy. So we are using venetoclax in combination for NPM1 mutation, FLT3 negative, IDH1, 2, and any non-CBF patient, elderly, particularly with comorbidities. And the FLT3 we have, for FLT3 we have sorafenib, and we have midostaurin, and we are using more and more midostaurin, which is the medication could be taken at home without asking the patient to come to the hospital frequently. Now, coming to the consolidation, we know that in this recent meta-analysis published that high-dose RSC consolidation is interesting for low-risk cytogenetics, a little bit less for intermediate and not very interesting at 3 grams, but at 1.5 grams for high risk. So we are using a 3 gram meter square per dose for 6 doses for very fit patients who are at low risk as consolidation therapy, but frequently we are using 1.5 gram meter square per dose. And if CPX is available, we are using 2 cycles as a process of consolidation. But for non-eligible patient for chemo, we are using hypomethylating agent and rarely associated to venetoclax if the patient is in complete remission. For relapse and refractory, standard intensive regimens, but without fludarabine are used. For non-eligible patient for chemo, hypomethylating agent-based combination are used, and anti-FLT3 are used also, particularly sorafenib and midostaurin. For NPM1 FLT3 negative, NPM1 positive, as an induction therapy, venetoclax-based combination are also used. And we have some rare patients with anti-IDH1 and the IDH2 mutation and relapse using EVO or enazidenib. For acute prognostic leukemia, we didn't change block the approach. We are using A2-ATRA for high risk plus cytoreductive chemotherapy, and without cytoreductive chemotherapy for non-high risk patient, but we are shortening the consolidation by reducing by 1 month or 2 months less duration. For allogeneic transplant, we are not in disaster in Lebanon, so we didn't defer the majority of allogeneic transplant. But for some patients, one non-urgent allo can be deferred. We did it the first 2 months, and now we are doing on time, particularly for secondary or treatment-related AML, refractory to more than 1 induction. NPM mutation was MRD positivity after 2 inductions, and the re-emergence of MRD after the treatment, high risk according to ALN risk stratification and CR2. Initially, we cryopreserved the donor and the donor cells before starting the procedure. Now we are doing it classically done. If the patient had COVID-19, we didn't face in AML, but in ALL and CLL and 1 lung cancer patient had COVID. So the three among the 20, the patient positive for SARS in Lebanon. So for asymptomatic patient, 3-7 is still here. For elderly patient, hypomethylating agent. And for symptomatic, we delay until PCR and no symptoms, negativity and no symptoms, we are using hydroxyurea if the patient is the disease is proliferative, and a hypomethylating agent could be an alternative. For consolidation, we delay until PCR negativity and so on symptoms. Frequently, a hypomethylating agent are used plus minus venetoclax. And for anti-FLT3, anti-IDH1, IDH2, if they are available, we are using them. Allogeneic transplant is deferred until PCR negativity and no symptoms for at least 3 to 4 weeks. This is for AML. For ALL, recent studies demonstrated that monoclonal antibodies plus light chemotherapy are interesting to cure or to have long-term survival, particularly in elderly patients. Here we have many hyper-CVD plus inotuzumab plus minus blinatumomab in older patient with good overall survival. For Philadelphia negative, for Philadelphia positive, the last 20, 30 years, everybody know that new TKIs induced long-term survival, and probably with chemotherapy and ponatinib, we will have the same result than allogeneic transplant with the previous dasatinib, for example, or inatinib previous TKIs. So we are trying to go with light chemotherapy and light chemotherapy and TKIs for ALL Philadelphia positive without doing transplant or delaying transplant if the patient is in complete remission and it is stable. ALL Philadelphia negative, we like proposed by the big societies, lower doses of steroids, reduction of anthracycline dose, particularly in high-risk patients with cardiac problem, because you know that COVID will induce cardiac and pulmonary problems. A reduction of asparaginase, everybody talked about coagulopathy, so reduce the asparaginase dose, and no anti-CD20 if low immunoglobulins level. And we are more and more trying mini hyper-CVD and inotuzumab for sometimes blinatumomab. That problem, which is a bispecific antibody, anti-CD33, CD19, but the problem is more economical in some patients because this is not a cheap drug. For post-remission therapy, we are trying to with the maximum at home if the patient is complete remission and with MRD negativity, subcutaneous RSC is not bad. Lowering dose asparaginase is interesting. No anti-CD20 if low immunoglobulins level, and delaying intensification sometimes is preferable. And for maintenance therapy, we can do it on schedule, but we have to maintain acute neutrophil count more than 1,000. We are using also monoclonal antibodies when what is affordable and available, blinatumomab and inotuzumab, because of the importance of these drugs and for MRD positive patients before transplant. If the patient is MRD positive, we can have a higher and better result in transplant MRD negativity using blinatumomab or inotuzumab in first or second relapse. And here in relapsed and refractory ALL patient, you see that blinatumomab and inotuzumab versus standard of care induced a better result, significant better result. So these drugs are interesting in the salvage and relapse refractory. What we are using these drugs as proposed by other societies, the major societies in the world. Specific antibodies are used for inotuzumab and blinatumomab for BALL, but for TALL, we are conserving a salvage regimen, but considering dose reduction. For allogeneic transplant, it is not an urgent, if it is not an urgent procedure for the patient, we can defer it. Particularly for high-risk ALL and first CR and patients who are beyond second CR and beyond. But we have to discuss risk-benefit for every patient. And for patients who have COVID with acute lymphoblastic leukemia, we faced a case like this. There is systemic chemotherapy until PCR negativity and no symptoms. for Philadelphia positive TKI inhibitors can be given along with steroids, and sure, for CNS intrathecal chemotherapy and allogenic transplant deferred and PCR negativity and no symptoms for at least 3-4 weeks. We have to pay attention to interaction due to CYP3 inhibitors or Q2 prolongation when we use anti-FLT3, venetoclax, and current therapeutic options of COVID for AML. For ALL, we have to pay attention also to the interaction between methotrexate 6-MP and hydrochloroquine. Methotrexate vancomycin with antiviral used for COVID, and doxavancomycin with anti-IL-6. So supportive care also, we are using supportive care as proposed by the American Society of Hematology. Transfusion episodes are reduced by reducing transfusion threshold, hemoglobin below 7, platelets below 10 to 9 per liter, and we are using GCSF to shorten neutropenia for the majority of the patient. I would like to thank you for your attention.
Hello?
Thank you.
Can you hear me? Thank you very much, Ahmad. Beautiful presentation as always. We have to move to leave the discussion at the very end, as I told you. And now we have, before the discussion, Naeem Chowdhury from Riyadh. How are you, Naeem?
Very well, thank you, Bebe. So I will start.
Thank you.
Yeah, so what I did was I will just go over the chronic myeloid leukemia, the way we handled it, and I'll just make it based on a few cases rather than an overview of CML, actually. So what we did was, as we have to accept that generally the management guidelines should be adhered to as much as possible, and the risk of COVID-19 should be evaluated against the risk of disease and outcome. In Saudi Arabia, actually, until the end of February or mid-March, we were not too much concerned. We had our main, some meetings also at that time, and that was the last meeting, and after that, all the meetings and conferences were cancelled. Generally, for a newly diagnosed chronic myeloid leukemia, I think the treatment choices do not need to be changed. No evidence that any of the TKI currently approved will pose a greater or lower risk of acquisition of COVID-19 or worse outcome, except maybe somebody who has complications primarily from thromboembolic or pulmonary pleural effusions from some of the specific TKIs. But as a general rule, unless the patient has any complications, there is no need to change just because there is COVID-19 is in the environment and the patient remains symptomatic. So regular blood work in our thing was apparently is recommended, but was not possible in all of the patients, and it's not possible in all of the patients in the other peripheral hospitals. And it is also important to avoid neutropenia, unexpected pancytopenias that can not only occur with the second generation TKIs and also with the first generation TKIs. Looking at these things, how decided to manage the cases. We all know that the TKI do very well from all the data that we have existing over the last or nearly 2 decades. So how do we manage CML during the COVID era? What is the major restriction in pandemic? The major restriction in a pandemic that patients that are supposed to come to see you, we have like 30 to 40 patients in a week in my clinic that have chronic myeloid leukemia and are at different stages of treatment, from newly diagnosed to follow-ups and accelerated phase. So the major issues are lockdown. They cannot travel. Even within the city, when the Saudi government decided to put a lockdown, it was very difficult for the patients to travel, and it was difficult for them to get the permits as a specific permit as a patient to come to the clinic. And there was a general guidelines from the hospital to ask patients not to come to the hospital and the physicians to stay home unless they are on the service providing care, and to do their clinics as a virtual clinics. So the need to follow this requirement to contain the pandemic, reducing the risk to the patients and others by restricting their movement or coming to the hospital So we had to look at all these things when we decided how to manage them and how to avoid seeing the patients frequently without jeopardizing their care. That's the most important care. Luckily, in chronic myeloid leukemia, patients who are doing well and are not really symptomatic, they are almost like normal people who are going around their business in the community. So our virtual clinics, phone clinics, justified for serious illness and their management and how to manage such patients effectively in the view of these constraints. So when you look at them, what factors will influence your choice? Is it a low risk or the high risk? When do you call the patient to come in? We had to look at this one. Also, whether you would like to, as upfront, first or later generation TKIs should be used, how to manage them and how to, the side effects profile may be different. How will it influence your choice? Does the first line therapy matter more than the subsequent lines of therapy? How do you do the initial monitoring of counts? Patients can't travel. They cannot travel from other cities. The local hospitals, most of them are actually shut down almost, because I called the patients and they say, our hospital is shut off because they wanted to reduce the patients coming to the hospitals. Resource availability of the local hospitals, assessment of response, whether they have achieved a complete hematological response or earlier molecular response. Apparently that was not anymore the major issue at that time. Then the issues related to the patients, the residency status, whether they're local or distance, and what is the physician's understanding about TKIs and relative efficacy. So success is based on efficacy and tolerability of the drug in the COVID-19 era, and or how frequently are you able to monitor if required. So we know that the drug does good, whether the COVID era is going to influence, and what do you understand of how frequently to monitor? Can you modify this? So this is just a case. A 38-year-old female I saw was followed to the local hospital. I didn't see at the time, but patient was referred to me. She was a newly diagnosed chronic myeloid leukemia in February 2020. So-called was intermediate. This is the information from the local hospital. COVID-19 was still not an issue. The question number one was, what would be the choice of TKI? I mean, apparently the local hospital, I would have started imatinib, intermediate score, young female, but all of them are therapies of choice. So this patient was started on nilotinib. At that time, she developed moderate pancytopenia within 2 weeks to 3 weeks, and it was early March, and the COVID issues are building up, but still the lockdown was not there. So the next move before the patient came was to decrease the dose or change to another TKI. The local hospital, what they did was, with the moderate pancytopenia, they decided to change the medication to dasatinib without giving it. Maybe they were going into lockdown. This decided that pancytopenia would not be an issue with dasatinib, and so they started the patient with dasatinib. So the patient pancytopenia goes from moderate to severe, with severe pancytopenia, referred to King Faisal at that time at the end of March, and was labeled as intolerance to TKIs. When I saw the patient end of March, it was intolerance to TKIs. So at that time, the Riyadh goes into complete lockdown. It's like a curfew. And patient is from 200 miles away. So what do you do in this situation? I mean, this is not the only case, but they had a large number of these cases all of a sudden that were in early part of the therapy. Number one, is the patient really intolerant to TKIs? I don't think the patient is intolerant to TKIs. The dose was never actually adjusted and was switched to another. Should you hold dasatinib, switch to imatinib? Anyway, dasatinib was put on hold until count recovery. We did not put another TKI. We told the patient to go and get his blood counts done at the local hospital and come back to the clinic once the lockdown is a bit better. CBC is done at the local hospital. Some growth factors could have been given, but the patient was not labeled as intolerant. So when you select a frontline therapy for CML-CP in a new patient, I think given the COVID-19 restrictions and the efficacy of the drug, what should have been the most appropriate action in this patient? I think that they should have held the drug in the initial phase because the city was going into lockdown, and then restart at a lower dose if they were able to see the patient. That would have been a better choice rather than switching from one to a second generation, which caused more severe pancytopenia. This can happen, and if you have a severely neutropenic patients or thrombocytopenic, and on top of that, if they develop a COVID-19 infection, that can be a problem since the patient with corona can cause thrombocytopenia. as well as other immunosuppressive side effects. So given COVID-19 restriction, it is safer to hold and adjust the dose and give a longer follow-up rather than change and unable to follow the patient due to restrictions. That is the most important thing, is one should not, and this restriction is going to go on for another month, 2 months. So we have to be aware that rather than switching the drug, it's better to hold the drug for a while and then reschedule the patient to see or adjust the dose to a lower level rather than switching to a strong second generation TKI. Another case we saw was a 42-year-old male on imatinib 400 milligram for 3 months. BCR able was 11% from the baseline, so it was not an early molecular response. Tolerability and compliance was excellent. Now, due to the COVID lockdown, patient may not be able to travel. So what do you do in these cases? Whether you switch to a second generation TKI and return to clinic after 3 months, or you continue imatinib and defer decision at 6 months follow-up. I think in my opinion, as actually also from the recent guidelines from ASH also, I think what the decision was taken was to actually continue in imatinib and reschedule the patient to see rather than switching a dead patient. Because if you're unable to see a patient after switching to a second generation in 4 to 6 weeks time, that patient's reaction or side effects profile or pancytopenia or the reaction to the medication may be that's something that you don't want to risk, especially if there's no healthcare availability or restricted availability even in the local hospitals. So in general, the management guidelines should be adhered to as much as possible, and the risk of COVID-19 should be evaluated against the risk of disease and its outcome. So we all we know that at 6 months, if they develop at 3 months, and if they are the same patients, if they have less than 10% 6 months, they really have the same outcome. Case number 3, in the context of COVID, how do you manage patients on a TFR in COVID-19 restrictions? There was another 48-year-old imatinib for 10 years, last 5 years, complete molecular response or very deep molecular response. I started this patient in October 2019 on TFR when the had more than 4.5 log reduction. In March 2020, the patient was still in MMR. I did not do anything. And this is the time of the COVID when the lockdown went into effect at the end of March in Riyadh and all over Saudi Arabia. So in April, I called the patient on the phone clinic. Patient was said he cannot travel. No local hospital can perform BCR-ABL or draw the blood, because even to send the blood to King Faisal was a difficult issue. So what should be the next step? Do we need to find a way to come and have BCR-ABL done specifically at KFSHRC because patient may lose a response? It's like 6 or 7 months, within 6 months. Should I just go ahead and restart imatinib and discontinue TFR and see the patient later on? Or is it safe to come after a month delay for evaluations? What I did was I selected the choice number C. And why? This based on also on the data that most of the relapses occur actually in the first 6 months, and the patient is at the cusp of 6 to 7 months. And I decided to take a risk. Usually beyond 6 months, there is data exists that you can see the patients every 2 months. And I delayed the scheduling of this patient for another month to 6 weeks. Even if they tend to lose the response, they always respond very well to restarting of the medication. So I did not change the medication. I kept on the TFR. I told the patient to come after 6 weeks rather than forcing the patient to come for a BCR-ABL. That I would not have changed anything anyway. So management of TFR during COVID era, and from what I get and what from the guidelines and recently also published, this was before that, actually the guidelines, the patient with TFR can have their appointment delayed every 2 to 3 months after initial 6 months. And this is also a recommendation that just recently came out a few weeks ago from ASH, because the risk of relapse is very low. Beyond 1 year, it's even lower. Most of the patients who relapse within 6 months, and some of them will relapse, who tend to relapse in the first 12 months. So prior to 6 months, monthly follow-up is preferable, but may change to 6 to 8 weeks in difficult conditions like the COVID infections in the cities or the country. The risk of losing a response is there, but progression into advanced phase is very, very low. So you're still safe to make a patient travel and get exposed to a COVID infection. It's safer for the patient to stay home, talk to you on the phone, and if possible, get a lab results done at the local hospital, even if there is no BCR-ABL. The risk of progression in such patients beyond 2 to 3 years continues to decrease. These patients can be safely followed every 4 to 6 months for the patients who are already in MMR. So this is what I did was patients who are on a regular follow-up every 3 to 6 months, I just delayed them by by another 3 months. So patients who were supposed to come to my clinic and were in March or April were 4 months follow-up, I delayed them by the 3 months because in our opinion, I mean, in the data and whatever we have in our experience, these patients who are already in deep molecular response are undetectable. If they're good patients, remains compliant, there's hardly any case that's going to go into a progression. If they're able to do a CBC which remains normal, I think they can be safely delayed for another 3 to 4 months for a follow-up. So this is what we did. That during the current COVID-19 restrictions risk, these patients' appointment can be safely delayed by 3 to 4 months. And this is what we did. All the April and May appointments have gone to September, October. So that means the last appointment from January or December would be like approximately 9 months to 10 months, which in a regular for patients who are deep MMR or undetectable is, in my opinion, or and what the current situation is, given the ASH guidelines also seems to be appropriate as long as the patients are compliant. And as soon as the restrictions go over, we will call them and ask them to come a bit earlier. How do we monitor, provide medication during care? This was another issue. So how do we do this? What we have done was in our what we did was in our patients, all the patients are given a phone clinic. So what they do is they call the clinics, their medications are renewed. It's like a phone banking. They select their options and it tells them that their medication has been renewed and these medications are available. Their address is displayed. They're told to them, they confirm their address and medications are sent by DHL or the locals SMSA, that's the courier service, direct to their homes. So they don't have to travel from the cities. It is available. King Faisal has a contract with DHL and SAMSA to provide medications throughout the country. And it automatically goes, the patient picks up the phone, it's like a phone banking, and they get their medications. The one in the local hospital, we closed most of the pharmacies in the hospital and we opened a local pickup, a drive-through pharmacy. They come and they pick up the medications without getting in contact with any of the staff, any of the other case. It's a drive-through pharmacy. They call an hour before, the medication is ready. They drive through, get a sticker and pick it up from the window without getting out of the car and go home. So this way was one of the ways the King Faisal, our institution, decided to restrict the number of patients coming to the hospitals, but also providing the best possible care at the same times. Now, another issue with the chronic myeloid leukemia is how do we manage adverse events for patients who are on treatment? We have done virtual clinics with local hospitals if available. Some of our smart, there are 4 or 5 hospitals which have a contract with King Faisal as a smart virtual clinics where all the medication can be displayed into our hospital system. So you can look at the labs, what were done in the local hospital. Instead of getting them on the email or fax, it just comes into your integrated clinical information system, the ISIS system, and you can you can renew their medications. So that was a great help for us. And it's easy to have dose reductions patients so they're responding to therapy rather than asking them to come if there is any side effects. Discontinuation of meds, if required, is safe. Disease is chronic. And I think one has to judge what is the best outcome for a patient without making them exposed to a corona infection. So in general, again, the management guidelines should be adhered to as much as possible, but they can be safely modified as per the guidelines just published a few weeks ago also. And the risk of COVID-19 should be evaluated against the risk of disease and its outcome. I think this is the way we managed it. I'm sure a lot of centers manage it also. And we have done so very well. We have not encountered any advanced phase disease. We have not encountered any significant complications so far in our follow-ups in the chronic leukemias. Thank you very much.
Thank you, Naeem. A beautiful presentation. I agree with most of your points, being involved deeply also in the field of CML. Now, I think that we are running late. We are running definitely late. but I think that we can have 10, 15 minutes of discussion. So I would start with the questions that we left behind before. I think that there was a question of who wants to start? Who wants to start? I don't see any in the chat. I don't see any question, specific question. So are there still questions
There is
for,
one
please?
about effectiveness of chloroquine.
Chloroquine, yes, the effectiveness of chloroquine. So who wants to answer?
I just would like to say something about chloroquine, if you allow me.
Please, please, Mr.
We know that it's a great issue from the scientific point of view. Chloroquine is very discussing phenomenon right now. I think that because of the different dose of the chloroquine, for example, in Brazil studies, they use 1,200 milligram per day, and they closed early because of the toxicity. And in the Lancet studies also, they get into all different kind of doses into the studies, and we really do not understand. And we really don't have an idea about the effective dose, if effective, and we really do not know the toxic dose. For the rheumatological disease, generally we use 200 milligram per day, maybe for many years without any kind of toxicity, But the toxicity maybe appear in COVID-19 patient, not because only the dose of the patient, but also the effect of COVID-19 can cause, a kind of myocarditis and can cause a kind of endothelitis. So because of that reason, I think the written problem can occur. And I think that there is a big discussion for the Lancet paper, and maybe 1 or 2 days ago, 120 scientists declared a letter about the Lancet paper. So we really don't have any idea still about the effective dose of the chloroquine and the toxic dose. For example, in some cohort, the classical dose sometimes 100, 650, 1,000. These are very high dose, I think that because of that reason, toxicity can occur. In Turkey, routinely, we check for ECG before starting the doses and check the QT in ECG, and then after start a very low dose, about 400 milligram, not advanced disease, in the early stage of the disease. And we really do not know if it is effective or not still.
Yeah. In Italy, it was a general rule to give hydroxychloroquine the beginning of the pandemic. Now, the impression is that most of the people are discontinued, so it's no more in any guidelines or rules for treating patients. So it's because the impression, however, even without pushing too much the toxicity, it was not very effective.
Pepe, may I have a question? What is your personal opinion about JAK2 inhibitors?
We will have definitely, we have a great experience, but in Italy, Novartis has allowed the use of this drug, of the ruxolitinib in particular, free. So there were at least something like 50 or 60 patients who have been treated with this ruxolitinib. Now there is a commission in which I am part of it, and we have to establish indeed if it is efficacious or not. I think that anecdotal data are in favor of the use of ruxolitinib, and also I know is that Novartis is starting a big trial testing ruxolitinib against the best available therapy, what the investigator wants to do. What is relevant, however, is the ruxolitinib at the dosage which is proposed, which is the same which has been approved for the graft-versus-host disease, is very, very little, is 10 milligrams per day, 5 milligrams twice a day. And therefore, apparently, we do not expect it to have many toxicities and so on. And we do not know, of course, about platelets and so on, but I don't think that at this dosage there will be a big problem of hematological toxicity. So it's a trial that probably will tell us exactly if it's useful or not. Theoretically, as tocilizumab, which is an anti-IL-6, as well as other drugs which have been used in more advanced cases, it could be useful. There are logical bases to think it could be useful. But precise data, apart for maybe some anecdotal data, as I told you, or data from a Chinese group, but I haven't seen them. I haven't seen so far the publication. Apparently, we do not have data, so we have to wait for the data. Who wants to ask a question to Salam about HBS? HBS is, I would say, fortunately enough, in the countries where HBS is distributed, apparently, we have to look probably at what's happening in the United States, because you have in Oman a quite mild phenotype per se, and therefore this may provide some sort of protection. But because of the vascular activity of the virus in promoting endothelitis and so on, maybe it is, I would say that, of course, in Oman, you were not using chloroquine because of the high incidence of HBS disease. Am I correct?
Yes, because of G6PD, you mean, I'm assuming.
Yes.
Yes, so.
But for HBS, you are.
We have it in the guidelines still. I'm sure people are revising it because I think the data on hydroxychloroquine is clear for the severe cases, but maybe there is consideration for the mild to moderate cases of COVID. But for hemoglobin, for the sickle cell that we had, we did not need to use any of the therapies recommended for COVID, because they did not meet the criteria for initiating the medication. And I know in rest of the world, and particularly data from the UK, they have used hydroxychloroquine in some of these patients, but with the caution of G6PD that the patient should be they may hemolyze with this drug.
Okay.
So did you want to?
Yes.
Were you asking about hydroxyurea? I did not mention this, but all the recommendation is that these patients, if they are established on hydroxyurea, they should continue. We don't have enough evidence that hydroxyurea predispose them to increased risk with COVID infection. But we should not initiate new patient on hydroxyurea in this period, but if they are maintained already on hydroxyurea, they should continue taking it.
Okay, there's another question.
I think that Dr. Güray Sedam asked a question. I think that this question comes to me about the role of the defibrotide in protecting the endothelial cells. It seems very logical, but there are two studies ongoing right now. One of it comes from US and the other is from Spain. It seems very logical with the risk of the hemorrhagia, but we need to wait for the results of these two trials.
Okay. So are there some questions for Ahmad, for Ivina, or for Naim?
There is one question actually on the system which says they're asking about the what do you think about the drugs that can cause T cell depletion in hematologic malignancies? I think it's to the panel. So
Yeah.
from my point of view, what we have
Please.
done is we have not used any immunosuppressive therapy that can cause T cell depletion, specifically for chronic leukemias, until unless it's entirely necessary. For the even chronic lymphocytic leukemia, also we tried not to use fludarabine or even FCR, and
Naeem, even in acute leukemia, when you see the consensus of the major societies, they don't propose fludarabine. For lymphoma, for example, we don't use bendamustine, which is lymphosuppressive. So these drugs should not be used in the COVID pandemic.
That's really necessary.
Okay, thank you very much.
Regarding hydroxychloroquine, I was informed by Marseille group, that
Rossi.
Yes,
not our Rossi, other Rossi.
Yes, and in France there is a kind of study in earlier stage, and we are waiting for the result at the end of in June, I think. Are you aware about this? Because
yes,
a colleague from Paris told us that in 2 weeks they could have some result in a randomized study between in earlier stage that in advanced disease, in advanced stage.
No, I agree with you. I agree. So I think that if there are no other burning questions, maybe we can have, let's say, 15 minutes is conceivable. I'm asking the organizer. Hello? Birol? Onur?
It's up to you. You are the president, Papa.
You are the boss, Pepe.
I think that, yes, as we are missing, unfortunately, the final discussion, we can take these 15 minutes out of the discussion out the time that was reserved for, who is the person who is missing today? Tariq Mughal. So I think that we can start in 15 minutes by now. Okay. And Mustafa, you are the leader at this point.
Yeah, thank you.
Thank you.
Thank you, Pepe.
Good coffee.
Thanks, everybody.
Yeah.